because you're not counting and measuring all of the unidentified hypertensives. Does that make sense?
Well, do you identify your hypertension by someone's diagnosis or by the blood pressure in your EMR?
Well, we measure, when it's high, if you go into dermatology, it's high, you then have to be followed up in primary care. Some of that is white coat and all of the other stuff, but fundamentally we're measuring it and identifying it by HEDIS rules, which is really codes. Our registry is a little broader and looks at medicines as well, but the point is there's unidentified patients in everybody's practice that are walking around with a blood pressure of 180, ready for that stroke, and nobody knows about it.
So every medical visit I've ever been to, I've had my blood pressure taken.
Every?
And maybe, and I'm not a
podiatry?
Kaiser patient,
Okay.
I'll admit that. So our sense about asking that the hypertensives in your practice be in good control is that a lot of screening is going on in that health system. So it's not that we don't want the screening to happen, and please don't misinterpret that.
I guess I'm going to challenge, without measuring our prevalence, do we actually know that we've identified everybody?
And I will say from my own personal experience, my son went into an unnamed integrated health system and called me from the parking lot saying, "Mom, my bottom number on the blood pressure is 110. Is that bad?" So he went in and recognized the only reason he knows blood pressure is both of his parents are doctors. It runs in our family. But, you know, they weren't paying me to manage his blood pressure. So part of his point is you can't find a fever if you don't take a temperature. So you need to know your prevalence so that you know, that's a major factor of your success of your intervention. Because if you fix everybody, but you miss my son, big whoop, you really haven't solved the problem.
I mean, we do cancer screenings. Everyone gets excited about breast cancer screening, but we don't screen the same way for hypertension or diabetes. Diabetes you could debate, does it really help? But certainly hypertension we should be just screening for, and we don't as a society. Any questions on that? I'm being controversial here, I know I am.
I'm sorry I missed that last point because I heard another controversial point over here.
Yeah.
Michael, with respect to the issue of disparities on the sort of unscreened, do you have any either anecdotal or data suggesting maybe that you would see some differential screening rates so that even as you're narrowing the disparities, there may be a higher prevalence of minorities?
I don't know in our system, and I haven't seen, I'm going to guess somebody studied that, but people who don't access healthcare systems, which is going to be more minorities, are going to be screened less often. So I got to believe there is some disparity in screening rates, but I don't have numbers in my head. Yeah. Yeah, to me this is a big public health issue, and it tends to get less attention than the control rate. I think they need to be equal. When we started looking at our hypertension, we only had 200,000 hypertensive patients in our registry. Now our membership has grown, but we got about 600,000 now. So we've probably doubled our prevalence over the last decade, which was probably not a real doubling of prevalence, but an identification problem. I would be shocked if other people, and I'm still not sure if we identified every single person. I doubt it yet, too.
Yeah, so the prevalence rate for us is actually only about 19% of our membership, and we know from population studies it's actually higher than that. So there is a sizable number of people who are missing out on the benefits of what we provide them because our registry is only about 19%.
So you believe you have a lot of unfound hypertension,
Right.
even though
Right.
you've got this very proactive program to find them?
Yeah.
So you've been trying to get your question
Well,
in.
it's sort of more of a comment, sort of complimentary, you were talking about what it's saying and everything. I mean, from the standpoint that blood pressure measurement is performed, that's still different from actually doing a screening test, right? So there are a lot of offices in which the blood pressure is measured, but when it's abnormal, there's no lot of them don't feel that if they're not going to be the one that's managing it, they don't think it's their responsibility to
Well, I
actually.
also think it was the case of my son. My son was 19 years old in athletic at the orthopod. Not, if he was 85 on a cane, someone probably would have clicked in someone's head. But 19-year-olds don't look like they have hypertension, although in 30 years they do. And so I think that was the issue, is that, look like a hypertensive person, maybe someone think about it, but I think your point about aggressively screening so that even people who don't present as a hypertensive person in the right place are found.
Right.
In one instance, it was diagnosed in 100 people. So that's the other thing, regardless of diagnosis, no diagnosis, I mean, the point was somebody measured it enough that he was aware that it was abnormal, because he happened to have some knowledge. But it was performed, so what's the point of performing if you're not even going to take the action on it, right? So I think there's instances where they're not even measuring, but then there are the instances where it's measured, but there's no identification.
Well, there's the other issue of people measuring it improperly.
Right, exactly.
And
there should be the trigger, right? But at the bare minimum on identification, there should be a repeat, right, at the bare minimum. And something said to the patient, besides him self-directing to contact his lawyer.
Let's continue down that track. So I can bring back to the California Department of Public Health, the Department of Managed Health Care, to the Medi-Cal program, and we can work on that issue if you, the physicians and clinicians in this room, have a recommendation of what needs to change to help support action to protect that patient.
And I think a lot of it has to do with sort of development of that standardized sort of protocol. Because I think a lot of the issues come in the specialty offices because the specialists feel it's outside of their scope, and they've got an unwillingness and efficiency issues, right, that they can impact their ability to get patient throughput if they're responsible for all of a sudden managing a diagnosis that they're completely uncomfortable managing. So I think a lot of it has to do with developing some of these protocols. And our group is actually just doing that right now with our specialists with regard to identifying how to direct patients that do have the abnormal, that also leverage some of the support staff that don't exclusively fall on the physician, because a lot of the time our physicians feel overextended. How can we say that? Right? So from that standpoint, we're really trying to figure out how to support them in that, because, as you said, we can't manage a hypertensive if we're unaware that they have hypertension. Right? So from that,
This is a great discussion. I see Dr. Carlisle wants to get back in, and Dr. Mason. But Sylvia, let's see what you were.
But I think what he was talking about, he was having dermatology. So number one, it was, my cousin, the cardiovascular surgeon, probably knows more who to refer, and will probably know blood pressure. The dermatologist, and particularly if you're in practice with throughput is key, you need to make it easy to execute. So in a system where it's easy for derms, I think the average dermatologist in private practice has no idea where he's going to be. So I think if you make it easy to refer, if it's not burdensome, if it doesn't interfere with the basic practice processes to keep the doors open, it is more likely to get done.
and the other thing I think it depends on your physician structure, right? If you've got group physicians, it's easier to implement across the board and involve your specialists if you're multi-specialty. If you're contacting IPA physicians who are all operating independently, I think it's significantly more challenging to get that support consistent, right? Because they've got different alliances, allegiances, contracts with various people. And so from that standpoint, I think if you're talking operational, there's a whole other layer of challenge. But at the bare minimum, to have sort of a triage protocol, and that way it's incorporated is relevant.
okay.
So let's say I go into the physical dermatologist.
Yeah.
And because your rules say that the blood pressure is taken
Yeah.
and it's elevated, but there's no diagnosis of hypertension.
Right.
I don't actually expect necessarily the dermatologist to know that.
Right.
But I might expect the system to flag it, and does it if you do that, and what happens after?
So again, there's many ways to set this up. What we do is actually scoop out everybody's blood pressure electronically who was seen in a specialty clinic, and send them a notice to go to their primary care office and get a MA blood pressure check.
Involve the patient directly.
That's mostly how we do it. If we didn't, before we had that, the specialist was sending referrals back to their primary care doctor. That's the operationally easier way, in the sense you don't need fancy electronic systems, but the primary care docs didn't like, it's extra paperwork and stuff. But if I didn't have the electronic system, I just tell the specialist that has to be followed up, send them to their primary doc.
There's a lot of ways that the system
Oh.
there's a lot of ways that the system has to support the physicians from practice to get the efficiency and the outcomes we want. And it's not just all, doctors directing the
Well, I mean, it's really an interesting cultural thing, and I don't know if we have any sociologists in the room. When you ask doctors, what do they do? If I ask Dr. Ho, he'll say, oh, I'm a family medicine or internist. And you ask a dermatologist, they'll say, I'm a dermatologist. Nobody says I'm a doctor. Somehow we forget that after we start our residency, and now we're a specialist. And I think we got to actually, as a profession, change the culture. There's certain basic stuff that any doctor should recognize. This blood pressure is too high, and they need to follow up, or the patient's too obese, or they're not exercising. This is...
Yeah, I agree with you, but I think the system has to support it.
I would agree with it. I'm talking about systems, but there is a big cultural aspect that even in a system, when we started this, got a huge amount of blowback, because the specialists were thinking, I became a fancy specialist, why am I dealing with this stuff?
And I think if you figure, most people in California have PPO products, so they get to run amok. And so if you say, I don't prefer to the dermatologist, because I want to. I'm of the age and demographic, I don't really need, quote unquote, a PCP training per se. Have the professional side who said, yes, you're a skin doc, but humans are attached to the skin, so therefore you need to all of the care. Identify some folks and refer people to based on young folks, old folks, pick something. But I think a lot of it is talking about the professional culture. That,
Yes.
this isn't my job, I'm just, I'm just X.
Well, can we ask the integrated groups that are here what they do in that circumstance where Sylvia's son is found at a specialty appointment to have an outrageously high and stroke range blood pressure? What is the right protocol at that time for that person? I mean, I would think that having that person have that moment be seen at least by a nurse practitioner who has hypertension knowledge would be much better than saying you need to go see your PCP. That could be a lag time that's scheduling.
But I think we go to, did that wildly abnormal blood pressure, which was noted by my friends because we had high blood pressure in my family, did that trigger, was it, did it trigger something in the PHR or the brain of the observer? I think part of it, and that goes back to the culture, and you're looking and you're paying attention and you notice and you have a plan that, and I think that's more of the issue that's prevalent in the identification.
So people aren't always with us. We have had the Measure of Pressure Down campaign presented here, which is to say every visit the hypertension should be measured, the blood pressure should be measured, and actions should be taken, protocols should be followed. So there are systems out there that are readily adoptable, and we want to encourage this passion, and we want to encourage all of you healthcare leaders to be proactive at the systems level to make it easy to do the right thing. And Bahar gave it up. You were going to
So
say.
we're from an IPA, and what we collected is the data for hypertension. We saw that it is being done in the specialist. But what the specialists don't understand is that the patients don't go to their primary. They only go to the specialist. Even at higher, once they get a referral, they no longer go to their PCP. They see the specialist. And so when we told them about doing these things for hypertension, they didn't want to because they're so, they've done the specialty education. So we have to have actually a paradigm shift with that group to educate them that they also need to be physicians. And that's where our problem is. They won't even work with our pharmacists who try to
very variable. There are many docs where if they identify any medical problem, the first thing they say is, go see your PCP, I don't deal with that. They're not comfortable. There was a while where they weren't allowed to send pre-ops to insurance, but the insurance weren't paying for it. The ophthalmologists don't even own a stethoscope, you know, so they couldn't do these things. So it's very variable. There are many docs that do exactly what you like, and there are many docs that don't. And often, I'll refer to patients with high blood pressure, and when they come back, the blood pressure is fine. They're nervous in the office, but that's fine. You'd rather check it than not. But I think it's just part of the real world out there that some docs only want to visit a specialty, and some people will see this and make sure they do get follow-up. And if you're being cleared for an orthopedic problem, I would think that you have to fill the forms out, and on the forms probably would have been a blood pressure, which would have been a reason that you would have had to refer your son.
Maybe if there's a reimbursement incentive, maybe then they'll do it.
Well, you know,
Maybe you should take that to
I actually think in the orthopedics defense is that the problem here, I'm showing you the people that got identified and it was confirmed hypertension, but many, you break your leg, you go to the orthopedic surgeon, and gee, your blood pressure's high, what a shock. And after they do that 5 or however many times where they might follow up the patient, they realize high false positivity rate and they can get disillusioned. So we need to do this thoughtfully, and there are human factors issues as to why some physicians might stop doing this. I'm not totally defending the orthopedic guy, but there are a lot of false positives in that kind of detection.
I mean, there's that story we've heard forever, maybe like Nordstrom's and the tires, but where people with tires were picked up with breast cancer at the ophthalmology office and all those things. It's a powerful story, but I assume it doesn't happen.
I'm glad they're getting out. I thought.
So what about UCLA? How do you deal with that systemic issue where you have a hypertension patient flagged in a specialty appointment? What's the process that you use?
Very similar to Steve's idea. It's going to be sort of a message, follow something to PCP. And then when you report out in their assessment plan, there's just they're not looking by the time. So it says, they need to start to bring it back to it.
So do you think that some of you who are more passionate about this issue might want to look at a process improvement together? Or do you all want to do it separately?
You asked if we would go to all the specialists and tell them to act like that. How would you take care of it?
Oh, this is.
Together, there's collective impact,
Well, again, if you have an EMR, the EMR can look for anybody with a high blood pressure and then scan and get back to the primary care doctors. If you're doing it only by looking for a diagnosis code, that's a whole different thing. Because as Robin said, the orthopod's probably not going to diagnose hypertension. But you could find all the hypertensions that are put in the EMR.
Right, that's true.
Yeah.
Dr.
Yeah,
Kanter,
yeah.
so when one of your specialists has identified a blood pressure that's high, what do they do? Do they refer back to the primary care?
I'd like to say we had one system, but we actually have 2. So some of them will, I mean, if it's really high, they'll, over 180, they'll send them immediately to urgent care or someplace. If it's just, modestly high, some of them will send them back to the primary care doctor. Some of them, we've got agreements where our electronic records will notify the patient automatically. And to make it easier on primary care, they don't actually see the physician. They just have a medical assistant measure the blood pressure in primary care. And if it's normal, which it is a large percentage of the time, they go on their merry way. If it's high, then they get an appointment with their doctor. And if you send them all to see their doctor, you're going to spend a ton of doctor appointments following up pain from a knee fracture or whatever that elevates the blood pressure.
So our host here, Steve Chen, assistant dean here at the School of Pharmacy, genius on research, has something to add.
Quick, something to share that I think might interest you. In our CMI program, we have, just as the second day, we process with about 4 different IT-embedded algorithms
said it would be in charge, and whether or not the patient could be enrolled in the program. And it's done actually very efficiently. We don't spend any R&D time on that. We have some clinical pharmacometricians who take 15 minutes to an hour who are trained to do this very well. Follow around and then look at, what do they sustain high blood pressure, or if someone needs to do for another one, they have one at one time, and we pursue those things. So we do a good job of capturing the very patients we talk about, if they have that number in the system. I think that's what meaningful use is supposed to do. I think I actually have video messages as well. I just don't know how to solve it.
Yeah, I mean, to us, some of the trick was that many specialists don't measure the blood pressure, at least in our system. And I still think that my daughter gets care outside. She works for Blue Shield, and they're funny, and they don't offer Kaiser as insurance. So she goes outside, and they don't, her doctors, at least the specialists she's seen, don't measure blood pressure. It's just, and you actually have to train the office staff in the specialty clinics, or they'll do it wrong and make a bigger mess than not doing it. So I'm actually sorry we're like getting totally sidetracked here, but
Blown away by that number, 14% of patients.
it's supposed to come out in press in a few weeks, God willing, one never knows. Yeah, that's interesting.
Well, so it does sort of lead to the idea of a potential project. Look, what are we doing as a community? What Mary was saying, in a collective action sense.
Yeah, and now I remember the point I was trying to make is it's not just sweeping through the medical record. That will help. But if the specialists aren't recording it in the first place, there'll be nothing to sweep through.
But would it help, say, Sylvia, Blue Cross, United, Kaiser, if you worked with, say, the pharmacy, the community pharmacies like Ralph that we have here, and others to do a more, some sort of a screening program? And would that help your system?
Yeah, I mean, a lot of the drug, they have blood pressure machines sitting around. Well, yeah, but it could be.
Some of them are. Some of them actually offer to forward the information to the doctor, so they have it send you things, or you can see it yourself. Some of the drugstore ones actually have something to develop that. I don't know how well it is.
Lauren, could you just hear that statement by Dr. Dewayne King about whether some of the pharmacies, so Lord Sereno is with us, Ralph today. Ralph is partnering with United has partnered effectively in San Diego with our rightcare, University Best Practices there, and also with United on a variety of community pharmacy programs. But what Dr. Dewayne King was just asking is whether you have the capacity to communicate the blood pressure information back to the primary care team. And I think that's one of the stumbling blocks that we've seen is we don't have functional clinical information exchange, and maybe that's improving.
We do right now. What we have is, for example, for daily carb testing, what we do is every month we have a screening event at each of our pharmacies for blood tests. And every time we see one that's out of range, we always get with patient consent a way to communicate the findings with their physician. We need their consent to do this. So everything is done kind of in the old-fashioned tax kind of way, so there isn't a high-tech information.
You're talking about a healthcare fair where you invite people in and do something.
Correct.
Yeah.
So the person who walks in and has a machine there takes some blood pressure.
We just collaborated with Rite Aid, and with Rite Aid, they can do it electronically. So our patients go there because they can't go to the clinic or see a physician, and those care coaches that they have are able to send it electronically back to them.
That's interesting because I know a lot of systems, and ours, I'm sure, would not allow others to put information into the system.
It's a proprietary platform that we built with them. So it is just
Yeah,
we're in the infancy phase, but we sent 660 patients to them who were not able to come to their primary, and they're doing an amazing job with the care coaches and the medication.
So a project that hasn't been mentioned here in LA yet is that Blue Cross Blue Shield and the Cal Index.
Oh, Cal
Cal
Index.
Index.
In most cases, Blue Cross Blue Shield is the same plan. In this case, we're competitors. They're always
Except you're collaborating on this very important effort.
collaborating sometimes, but yeah.
Sometime.
Try to get functional clinical information exchange so that we can get beyond this barrier.
So not at all directly related, but just the thought with regard to these retail pharmacies. Is there any way that we can get around some of the consent and ticket issues with regard to medications that patients pick up at cash prices or whatever, and that don't leverage their insurance? Because a lot of the medication compliance issues actually turn into something where they're paying cash because they don't want to hit the limit, and then ask us, we just don't get the information, but they'll tell us they want to take it. And so from that standpoint, there's a gap, right? Because that doesn't get billed to anybody, nobody knows about it, but at the same time, the patient continues to flag and show being non-compliant with the meds, when some patients are not.
The way that we get around that is our usual and customary prices that we use. So a lot of the chains have like $4, $10 special, and a lot of patients pay cash with that. Us, if you have a third-party billing, that's our usual and customary. We actually do bill the insurance. So at least for Ralph, the insurance companies know when they, even when they pay
So
cash price.
if somebody pays $4 for 100 hydrochlorothiazide, you then bill the insurance company anyway?
We do.
Wow.
Doesn't sound legal, but okay.
And that's changed because most pharmacies
Can-
do that now. So before that was locked in, and now it's happening. So companies like Vertical, for example, can consolidate all their information. They tend to get 95% of bills.
Does everyone do
Not
that?
a universal.
I think like Canada does that, or-
I'm not going to get through my slides here.
Okay, this is a great discussion that will continue next month. I encourage you to come back. We want to make sure that
Well,
Dr. Kanter will still be up there.
I will still be up there next week. No, I actually,
Thank you for sharing that number. It really
I prefer this to going through my monologue. So this, if no one else is upset that they'll, how much, it's, what is it, about 1:30 now?
just keep going.
Just-
Yeah, the idea was to stimulate this kind of
Well,
conversation.
apparently we
Rather
did.
than before or after.
So yeah, what I don't want to do is run too far over, Sue. When do I have to be done? We stop at 2. And I wanted to talk, you wanted to talk about our titration algorithm. So what do we need, about 10 minutes for that? Okay, so let's see okay, so I wanted to talk about something that you might not think of as being part of the medical care system, which is people who don't speak English. Big determinant of health, cardiovascular outcomes. There's a lot of literature that people who don't speak English have worse outcomes than people who speak English. So one approach would be to say that's a societal problem. Everyone in the country should speak English, and let someone else fix the thing. And I can't say that's totally wrong, but we created a language concordance program. And basically we had our physicians who were fluent in Spanish get tested for Spanish, so we knew they were truly fluent. We then said, we had Spanish-speaking patients seeing non-fluent doctors, and our Spanish fluent doctors had their panels filled up with English-speaking patients that didn't need that skill. So we realized this is kind of stupid. It's not a system. It's haphazard patients just picking whatever doctor happened to be up. So we said, let's try and match the patients better. We put in a little bit of a financial incentive and created a program, and it says there's 23 languages, which there are, and that was mainly for political reasons, because the guys who spoke fluent Yiddish said this isn't fair, we're excluded. But it's mostly Spanish, some Chinese here. And bottom line is, why is this important? We actually measured then the percentage of primary care visits where the Spanish or the LEP patient was matched with a physician fluent in the language. Started at 24%, we're now up to 43%. And so this has been a big success for us. Partly this is actually cheaper if you don't have to have interpreters in the room. That's actually a big expense for us and a big inconvenience, but it's better care all around. Med-adherence is better, there's a bunch of stuff. But why? For cardiovascular disease, and you'll see in this column we've got Spanish speaking and then everybody else. Most of those are English. And you'll notice that in general the Spanish speaking patients are a little bit worse in these three indicators here. To me, what's exciting when you look at lipid control, and I apologize, we don't measure this anymore, but that's not the point. If the Spanish-speaking patients have a Spanish-speaking doctor, that disparity essentially vanishes. So this is really interesting on how you can deal with disparities by creating a system that is different. And this is sort of what I was getting to in my slide. There's another contingency that I'll talk about. Some of this may be culturally responsive care, and most of our Spanish-speaking doctors are Latino, but not all of them. Colon cancer is really interesting because it actually is higher in the Spanish-speaking patients by a huge amount if they're matched up with a Spanish-speaking doctor. I don't know all of the details of the discussions that go on with colon cancer screening, but it's somehow more effective in your native language. So I point this out as an example of system interventions that one can take that will remove disparities. Right. Yeah. Right. I think language trumps culture, frankly, but yeah. You would be concordant in this chart. If you're fluent in Spanish and pass this test, you would be in this column. This is language. It has nothing to do with the race, ethnicity of the doctor. If they're concordant on language, the disparity for lipids and colon cancer goes bye-bye.
Are you actually trying to train some of your physicians and other clinicians in learning Spanish?
That is what the politics in our group were. We'll send everyone to a course and they'll be fluent in Spanish. In reality, it's taken me, 58 years to learn English, and I still struggle with it. So we have had a few doctors really dedicated. They're going to an immersion program. But by and large, I think it's just moving the patients around so when somebody's Spanish-speaking or Chinese-speaking, they get matched up with that doctor preferentially. And we weren't paying that much attention before. So that's a much easier lever to pull than teaching someone to be fluent who... It's not easy to learn a language. Yeah. We created training programs. I think we've had about 8 doctors. And they were like moderate, and we got them from moderate to fluent. It's not, it's like learning a new language.
You know about we educate our students and we send them to Spanish for medical day.
Right. There's literature that would suggest if you don't speak fluently, you may be more dangerous than if you... A little bit of knowledge may not be a good thing. And so for us, if the physician isn't fluent, we like an interpreter in there, although we leave it to the judgment of the doctor on this. Okay, so now we're really getting low on African Americans. They're at higher risk of complications from blood pressure, higher risk of stroke and renal disease for a given blood pressure, and they have a higher prevalence. So this is a really big population.
I've never seen that number before. I don't know whether everybody else has seen it. 3 to 6 times greater risk of fatal stroke. That should make us all gasp.
I don't know. Are people surprised with that? Yeah.
That's why I'm not guessing because I know it's that's part of the issue of language is not the only fix to healthcare disparities.
Right. So this is a high-risk population that should be screened more carefully and treated with high control rates. So if you have a disparity and the control rate is lower in African Americans, it has a bigger impact than Caucasians. Right.
Why is it 3 to 6 times greater risk of a fatal
They don't, I mean, I actually don't know, but this,
I mean, maybe there are also access issues or not being there to the early signs detections, right? There could be other issues besides just the physiology. It could be if you start to have this symptoms, but it's harder for you to get somewhere where you can be seen timely, you're still
yeah.
going to die, right? Higher probability if you actually had direct access to care, it was right there, the hospital was next to you, higher chance of long-term survival. But if I can't get there, even if I get there, I have to wait 3 hours, or there's 16 people
If you're, this is published, and I don't have the reference. I can get it for you if you want it. Some of this may be hemorrhagic versus ischemic stroke differences, because if it's more based on hypertension, maybe that makes a difference, because that's not just hypertension-related strokes. So there's a whole bunch of barriers here, and I think I'm running out of time here. So we actually, African Americans have to be on a more salt-restricted diet than Caucasians by about 500 milligrams or so. We've trained our doctors to try and build trust in that community, which appears to be a bigger issue based on prior malfeasance with research activities. And we actually have some storytelling videos of African Americans explaining why it's important to them to control their blood pressure. That was shown in a randomized trial to help the disparity. We put in a bunch of these things. We still have a BMI difference, which we haven't fixed. In any case, I'm going to blast through this, but bottom line is we did actually remove, this is colon cancer, I'll skip that. If you look in the New England Journal, at least in our Medicare population, we remove the disparity between African Americans and Caucasians with respect to markers of cardiovascular disease. The editorial, actually the article blamed this mostly on integrated healthcare delivery, which I think is wrong. It's all the stuff I've been talking about. So Jennifer is going to finish up and take us home in the next 13 minutes, because I guess by overwhelming demand and Hattie's insistence, she wanted us to talk a little bit about our drug treatment algorithm. So if you don't mind, I'm going to invite Jennifer Polson up here.
Yeah, so before you got here, we were talking about how the university best practices generally, the leadership wants more use of protocols. And thank you for sharing your specific protocol that was created from JMC8, after JMC8. So this has been passed out to all of you, and we're hoping to make an effort across the system to get protocols pushed out to the frontline teams.
And if your protocol is different than the JMC, I'd love you to explain all that.
I don't think we're different.
So it's basically the JMC.
Basically, yeah, I don't think